All right. So good morning, good afternoon, and good evening, everyone. It's so nice to see all of you here today. My name is Erin. I am an animal biology student at the University of Guelph in Ontario, Canada, but I'm originally from Indonesia. It's so exciting to see all of you here. I'd also like to make a quick introduction to Dr. Deborah Thompson, who is the founder of One Health Lessons, who's joining us here today. And of course, our two lovely guest speakers, Dr. Anna Radford, who is a consultant in pediatric surgery with a special interest in pediatric urology, and also Dr. Leslie Brooks, who is an advocate for One Health, and is a veterinarian. If perhaps Dr. Radford, if you'd like to introduce yourself really quickly.
Yeah, hi everyone. So my name's Anna and I'm a children's surgeon, specialty interest in urology. So that's any surgery involving the kidneys, urinary tract, bladder, and have a particular interest in children with spina bifida.
Thank you so much. And Dr. Brooks?
Yes, hey everyone, thanks for joining us today. I am a small animal veterinarian in the DC area, Washington, DC area of the United States. I've practiced in small animal general practice for the past 10 years, doing a variety of things, working in my own house call practice, going to visit people in their homes, to vaccine clinics, to a specialty center. And then now I'm pursuing a policy fellowship in DC. So excited to be here, and so exciting to see so many people from so many different backgrounds in so many different countries. Thank you for taking the time for this.
Yeah, it's super cool that all of you are here again. Thank you once again for being here. Just as a reminder, please make sure that your mics are all muted, and please try to have your videos on if possible. But I'd also like you to keep in mind that this session will be recorded. Dr. Brooks, anytime you'd like to start?
Yes, can you make me the host again, Erin, please?
All good.
All right. Okay, so I'm going to share my screen, you guys. We have a PowerPoint presentation. And if you haven't already, please go ahead and put yourself on mute. We're getting just a bit of background noise. All right. So the intention for this is to be very interactive. And so we definitely want you all to participate as much as possible. Me and Dr. Anna put this together just to kind of show how similar human and veterinary medicine is and can be. And we had a lot of fun, really, mostly focusing on the cross-cutting issues and the things outside of your typical straightforward medicine and treatment that's similar, but all the other things that are similar as well. The challenges, the barriers, and the successes. So as we go through, we're going to ask you for questions. Feel free to type your answers in the chat, or if you want to talk in person, go ahead and raise your hand, and then I'll just ask Erin to just call on you in the order of the hand raise, and we'll let you take the stage. And then bear with me as I navigate technology through this as well. And again, like I said, it looks like we have a variety of people from the human side, the animal side, already working in the profession, and then students as well. So exciting to see a variety of people here. All right, so we'll just go ahead and get into it. So this we're presenting as a One Medicine case study with the ultimate goal of determining from you, the audience, if our patient that we're referring to is an animal or a human. So we'll just get into it. All right, so the history and presenting complaint. And just as I'm from the US and Anna's from the UK, so I know there's people from different countries here. So if we say something that doesn't make sense, or if at any point you want to throw in information about your own country, of how it's different or referred to in a different way there, we're open to that. So the goal is that we're all speaking the same language, even if it might, be different words. So, okay, so the patient's name is Poppy. She is a female. She's 2 years old, and she's up to date on her vaccines. She gets her regular health visits, and she's typically healthy, doesn't usually have any concerns from her caregivers. She has no known allergies. Today, she is in the clinic seeing you because her caretaker has some concerns. Sorry, I'm also admitting people as they show up. Okay, so she's been a bit lethargic over the past 1 to 3 days. She seems to be somewhat incontinent, so she's having urinary accidents. And that's highly unusual for her. And then finally, her caretakers are just like, she's just not acting right. So in the southern part of the US, we would say this is called ADR, so ain't doing right. The northern part of the US, we would just say more properly, she is not acting right, so NAR. So the main thing is she's a bit lethargic. She seems somewhat incontinent. She's having urinary accidents, which is not normal for her, and she's just not right. Okay, so what would be your next questions to the caregiver as you're taking your history here? Again, you can type, what questions you might have for follow-up in the chat, or if you want to raise your hand, Erin can call on you. Okay, so Deb said, is she eating and drinking normally? She seems to be drinking somewhat normally, although she usually doesn't drink much water. She's not much of a water drinker. Her appetite has been a little bit decreased recently. She usually has a good appetite, eats a couple meals a day, a couple full meals a day, but the past few days her appetite's been a bit off. All right, and Simon says, when did you first notice the incontinence? Just yesterday, it was obvious, but now that the caretaker was thinking back on it a bit, she thinks there might have been a little bit of urinary accidents the couple days before as well. And Anna, feel free to jump in as well if you want to give more answers too. Oh, there's a question. Okay, has she been spayed? Well, we don't know if this is a animal or a human yet, and so it'd be kind of odd for a 2-year-old human to be spayed. So I'm not going to answer that question. I'll hold off on that one. What is her temperature? We'll get to that actually in the next slide. So I'm going to hold off on that one as well. Did she cry while passing urine? She did whimper a little bit one time and complain about not feeling comfortable right when the caretaker noticed she was passing some urine. Okay, William says 2-year-old, other behavioral changes. I'm staying within the history, whimper, crying, eye contact, smiling. Anna, do you want to answer about any other behavioral changes?
I think that sort of covers it. As we would probably say, the parents just feel they're not themselves would be our terminology. But the main thing being the urinary incontinence and lethargy. And I think to make the spayed question, we can deal with that and just say, not spayed.
Perfect. She's not spayed. And then Simon said, okay, the incontinence question a bit cheeky. Okay, so it's actually, she's like 2.5-year-old. I know it's kind of broad. I should have probably put it in months, but yeah, no, she's like 2.5 years old. Mucous membrane color, we will get there on the next slide, but it is normal.
I think Courtney had a question.
Oh, go ahead, yeah.
Yeah, is there a strong or particular odor to the urine? So it's a bit smelly, it's a bit fishy. But difficult to describe the color.
All right. All right, I'll go ahead and move on to the next slide. All right, so now you're going to be doing your examination. So her heart rate is 130 beats per minute. Respiratory rate is 20. Her temperature is 100.7 degrees Fahrenheit or 38.2 degrees Celsius. Behaviors in the exam room, she's calm and subdued, but very nervous. Tries to hide with her caretaker and doesn't want to sit still for the exam. You try to do a good oral exam in the mouth and ear exam with the otoscope, but she's somewhat resistant to it. Her lungs do sound clear, but she does tense up a little bit when you touch her belly on abdominal palpation. And again, she tries to hide with her caretaker. All right, so with all of that information, which is not much, I admit, what would you want to be your next steps? So Deb, you want to collect some urine? Yeah.
I'll come back to that in a minute about collecting urine.
And Katerina, collect urine. All right, so I guess for all those who want to agree with collect urine, I don't know how well you're accommodated to Zoom, but you can maybe like go to the reactions and put like a heart sign. So for all the people that want to agree with collecting urine, maybe like put the heart. I think that's an option. If it's not, we'll pick a different one.
Yeah, so skin turgor. I think Williams asked about skin turgor is how I would describe it, about tenting. So it does look a little dehydrated. I mean, as the caregivers said, not particular fan of water anyway at the best of times. And in the last 2 days, because of the lethargy, hasn't really been interested so much in food and drinking.
All right, and then we have some others. Try and carry out an x-ray or an abdominal ultrasound.
And some bloods. So you approach this subject with the caregiver and they feel like Poppy's going through quite a bit, and they ask about how you go out taking bloods and are you going to sedate Poppy to take bloods? And you say that's not your normal practice. And the caregiver's not really keen on taking bloods at the moment, so doesn't give you permission. Rain and the feces are normal. Good question. So mucous membranes, yeah, again, I'm not going to tell you about the colour of the mucous membranes, but a bit like the skin, maybe a little dehydrated, a bit dry. Same with the tongue.
Okay, and Courtney, inquire about significant medical history, any hospitalizations or surgeries. Has she had normal development to this point? Those are all really good questions, and everything is yes, normal to this point, no previous hospitalizations or surgeries, but those are really good questions. Ooh, Deb, anybody else sick at home? No, everyone else is fine. That's also a good question. All right. So we'll move on.
Yeah. So
Anna, I'll go through for you. So just go for it, and I'll just click the things.
So I mean, we've spoken about the blood tests, and the caregiver is reluctant for blood tests, but there's been a lot of calls for urinalysis, and I'm actually going to ask people again in the chat. I'm going to have a bit more interaction here. How are you going to collect the urine from Poppy?
This is good. So Deb says free catch, and we have another comment that says cystocentesis. Dr. Anna, I was curious, do you guys do cystos in humans? I don't even know.
Yeah, so we do. So I think this is it's gonna throw up one of those big problems we were talking about that is an issue for all of us. So cystocentesis we do use if you're worried about contamination, or if there is an anatomical reason why you can't access the bladder. So we do have children who are born with urogenital abnormalities. We have them born with cloacas. So passing the urinary catheter is extremely difficult because you can't identify the urethral opening. There is just one opening. And so if you feel that the neonate, so, tiny baby may have a urine infection, the only way to do it is to get a suprapubic, what we would call suprapubic tap or cystocentesis. And it probably is the gold standard in terms of preventing contamination, which is something we'll come on to about why it's a challenge. Mark Godwin said sterile Pampers. You can get Pampers for animals. I've seen them. So
nowadays you can almost get anything for animals.
In humans, children, we do the same. We put pads in nappies and cotton wool balls in nappies and syringe the urine off. That is sort of the main way that we go about it. We also have little collection bags that are quite easy to pick, and that's particularly good for small boys. So I think Garang was saying suprapubic catheter. I think that's similar to cystocentesis. I think to get a urine sample, that's different to blood sample. I'm just looking at Simon's comment. I think the issue is that for me, blood samples will tell me if there is an infection or inflammation going on somewhere, but it doesn't necessarily tell me where. So I would normally culture from where you think there might be an infection. I'm assuming it's similar for veterinary practice.
Sorry, I was thinking more from the point of view of parental consent.
Okay.
If they weren't consenting to a blood sample, are they likely to consent to cystocentesis or even the urinary catheter being placed?
Exactly. I mean, we do have most of our parents are running around after the children with a sterile jug trying to catch the urine sample. So all
right, I'll move through the urinalysis results, which
so someone was asking about color earlier.
yes, so there you go.
There's the answer.
And yes, and to we didn't really give a complete answer here, but the way it was collected, yes, because of all the concerns with, it's either a young patient or an animal, and caregivers are also often, very protective of that. We did the minimum invasive procedure, so it was collected free catch or via Pampers, sterile Pampers.
So the specific gravity is normal in essence. The pH is slightly raised. You've got 3+ of leukocytes coming up. Proteins present. And there's also some blood. And you get microscopy back. Now, microscopy tends to come back within 24 hours for human samples. And that is raised in terms of white cell count. And there is a slight increase in the red blood cell count. So what are people's thoughts? Is this abnormal, normal?
Kimia says definitely culture is next step.
Yeah. So, I mean, it's always difficult to say, isn't it? I mean, I think this is abnormal given the clinical history. Because of the nature of the way that it's been caught. Certainly with children, you can have a dipstick that looks like this. And even microscopy that would look like this, and it be contamination, particularly in young girls, because of the vulva. And I think veterinary practice has the same issue. Sorry, can someone just mute? Yeah. So I think veterinary practice has the same issue with contamination and hygiene. So urine culture will be.
I'm trying to find the person who's unmuted. Here we go.
बोलताना मी ऐकलं नाही नाही तेच करतो म्हणलं एक दोन दिवस
It won't let me mute them. Oh well.
जल्दी करो काय तुम्ही जल्दी नाही बुधवारी.
So on urine culture there is bacterial growth. You get that back in about 48 hours.
तुम्हाला बसून जायचं ते सामान घेऊन तिकडून मी एवढं मोठं सामान आणलंय स्टीलचं.
Sorry about that, guys. I'm trying to mute the person, but I'm unable to.
रिझर्वेशन केल्या ही हो म्हणली ना अजून बुधवारचे.
Dr. Hartkell, can you please mute? Thank you very much.
Okay.
फटाफट बोला मला आंघोळ करायची राहिली माझे दात घासायची राहिली संपलं का तू कशाला मध्ये डिस्टर्ब करलं आणि ती हे रे थांब
Sorry, Dr. Leslie. So if you are the host, then just the three dots to the top right of the person's window, and then there should be a mute option. Sorry to interrupt.
Okay, I think we might be okay.
Okay, cool. So bacterial growth, you broke E. coli, and that's back within 48 hours. And then 72 hours, you have a resistant profile to trimethoprim and cefalexin. But there is sensitivity to, I think, amoxicillin. So I think the next question is, I can see there are some questions coming up. And I think we'll get to those elements in a little while. So now what do you want to do? So you have a positive urine culture for E. coli. What would you have done whilst waiting for the culture results? Because they're going to take time to get back. So would you normally treat something like this when they initially turn up into your practice, into your clinic? Or would you wait for the culture results to come back?
Gerong said empirical antibiotics. Start cranberry extract at a minimum. If it was a farm animal, fluids are most important.
I mean, IV fluids is, it's not, or trying to encourage fluids is a good thing no matter what species we're talking about. There's a lot going for empirical treatment. Sarah, wait for confirmatory cultures if asymptomatic.
And then we got one for try to be careful about jumping to antibiotics if you're not 100% sure. That's probably good considering the culture came back with some resistance.
Yeah, I mean, I think everyone's coming up with very similar points. I think because this child, for me, it would be a child, but regardless, I think you have to do something, given that you've got a caregiver coming to you saying that they're not right. And I think the one thing that I've learned in my practice is that when you've got a caregiver saying that there's something not quite right, ignore them at your own peril.
Agreed, from the veterinary side. All right, I'll go ahead and move on. All right. Okay, here's going through treatments.
Yeah, so treat preemptively with antibiotics. Side effects. You may have diarrhea after starting antibiotics. So the normal stools may become abnormal. So how would most people treat this patient with oral or IV antibiotics? And what are the challenges for either one?
Yeah, they're saying oral if it's easy to do. Administration could be a challenge. Yeah, from the veterinary side, giving oral meds to a dog or especially a cat is always a challenge, unless they're one of those ones that just take it. I don't know, what kind of challenges have you seen from a child's side of taking it?
They just spit it out because they don't like the taste. So I think the pharmaceutical industry they try to make these medicines taste nice. I think the only thing that seems to taste nice is our Tylenol, paracetamol, oral liquid from a very famous producer. You try to give them a different paracetamol liquid, it normally gets spat out at you. But the antibiotics, it's a challenge. And then the parents tend to just give up because it's easier. Williams brought up a good point. He did say, can we reassess the vital signs and the fluids? I think the vital signs are static, and we've tried to push oral fluids. We're telling the caregiver to push oral intake over the next few days. And then there is reviewing in 5 to 7 days. And by that point, you've got your cultures back. So you may have to change the medication if the child has not got better just by cranberry juice and increasing water. Dogs aren't fooled by beef flavour tablets. No, I can tell you that from my own. I agree with that.
There's talk of teaching the caregiver on hygiene, method of cleaning. Sarah brings up a respiratory rate of 20 would be of concern in a child, possibly. That's definitely a possibility, which is why we included, increasing or the lung auscultation in the initial exam, which was normal. We're kind of contributing that to the patient's stress level during the visit and anxiety during the initial visit. So trying to take that into consideration as well.
I think a respiratory rate of 20 for a child, it depends on the age, because a neonate can have a respiratory rate of 30 to 50 and you won't be concerned. But if you had that respiratory rate in a 2-year-old, you would be concerned. 20 is probably about normal, on the lower end of normal, if anything, for a 2-year-old. So Ellie's brought up a very good point about cannulation. May be tricky for children and animals too. Yes, cannulation is how we would give IV antibiotics, and it's stressful for everyone involved. We'll normally have the caregiver with the child when they're being cannulated, which can actually make it even more stressful for everyone, including the person putting the cannula in. So
I'm just going to move us through just for the sake of time, because I want to definitely be able to get to the cross-cutting issues.
Yeah, so further diagnostics, we mentioned ultrasound scan, and I might show some pictures if we get a chance.
Yeah, stay tuned at the end. Anna has some really cool comparative images for those that like advanced imaging. I'll just kind of go through this slide really quick, because we don't actually provide you with an answer of if the patient gets better, because it was just focused on the history and the diagnostics and the treatments, and then follow up. So I want to go ahead and get through this and then to the next slide, because I want to see what you guys think. If you think our patient is a human or an animal, I'm going to test this out. If this link doesn't work, then we'll do a different route. So in the chat, I have a link to Slido, and I'm going to exit my presentation mode for a minute here. It should take you to a polling option where you can let us know if you need. Let's see, does it ask you for a number? If it asks you for a number, the number is 371041. I'm going to type that in the chat. Let me know if it has not worked, and we'll just do something else.
It's worked okay, Leslie, but it's just landing on a page. It's landing on the Q&A section rather than on there's no poll launched.
Aha, okay, let me do that. See if this works. Okay, now. Perfect, okay, good. So yeah, if you're able to go ahead and just put in your answer. Apologies if my slide share is being weird right now. All right. People are still pulling. I'm going to give it like 10 more seconds, and then I'll tell you the answer that everyone gave. I'm very impressed, because I felt like through our discussions, more people would have thought it was, actually it came out fairly equal. Okay, so 61% of you think the patient is a human, 30% think it's a dog, and 13% think it's a cat. So if we take the dog and the cat together, then the human still wins. So most people think the patient is a human, which I love, because I thought the patient was a human too as we were going through this. So I just kind of, I don't know. Go ahead, Anna.
It doesn't matter.
Yeah.
I think, it goes to show how much crossover there is, that it's 40 to 60 even, it's similar processes.
Yeah, and I just want to bring up this next slide real quick, because I think it kind of stresses the point. So I had a son 4 years ago, and I think I began to empathize with my clients, so pet owners, a lot better after I had a son. And I could also empathize well with my son's doctor. So I was at the hospital one time with my son, and his doctor couldn't, figure out, he couldn't give me a good answer for anything. He looked at me because I had told him I was a vet and that I understood his frustrations. And he said, being a pediatrician is sort of like being a veterinarian. And I was like, yeah, it is. Your patients can't really talk or explain anything to you. And then there's a lot of emotions and concern from the caregiver as well. So just.
And actually on the flip side, I don't have children, but I have a dog, and I go through the same stresses when I go to the vet with my dog as I think my parents go through when they bring their children to see me. So there is an appreciation, I think, both sides of the similarities. And with urinary tract infections, it actually goes for the older population as well. So, older human beings get urinary tract infections and recurrent UTIs, and older animals do as well. And there's a lot of other things such as arthritis in the care of older animals that are very similar. So I think you could say, although geriatrician's an old-fashioned term, being a geriatrician is probably a bit like a veterinarian at times as well.
That's very interesting. Can I also mention, you mentioned cloacas earlier. The only term I had heard, or place I had heard cloaca references in regards to like chickens and birds. So that was interesting that you brought that up.
Yeah, so it afflicts young girls, and they have a single opening for their urethra, their vagina, and their anus. So it is one of the urogenital abnormalities that we see, and there's all sorts of variations as well. So we see urogenital sinuses, where you have the urethra and the vagina opening into a common channel as well.
Interesting.
So, I mean, there were some crossover points.
Yes.
And we've sort of covered this in our anecdotes. Is it taking a history from the patient, trying to get a sample of urine or blood from the patient, and the challenges that brings. And the caregiver, having influence on the child or the animal, because mental stress is picked up on by the child or the dog or cat or animal. So if you've got a very stressed caregiver, you're going to have a very stressed patient. Patient compliance during exam. So I've been bitten by a child when I tried to look in their ears. And it's frustrating for everyone.
Yeah, that's so intriguing, because that's something that we often, are faced with as well, but I never considered it from a human side. Like, I kind of always say, oh, it must be easier to be a human doctor. You don't have to worry about getting bit, but that's not true.
We've spoken about administration challenges of medication and communication. We've sort of brought that up. And follow-up, treatment versus diagnostic. So antimicrobial resistance, I think, is the one that I wanted to bring up. And we were talking about contamination and fecal contamination. And that is a challenge. So in my clinic, I get sent children who have recurrent urinary tract infections, allegedly, but then when you actually look at the results, it is due to fecal contamination. And actually they've been overtreated with antibiotics. And antimicrobial resistance is a significant concern for us as human doctors, but I think in the veterinary world as well. I've certainly lost one patient because of a multi-resistant urinary tract infection. And cost of care. So I think this was something that came up when myself and Leslie were talking. In the UK, we've got a National Health Service. So for children, you do not pay for, even for the prescription for the medication. Obviously, veterinary care and human care around the world, there's different practices. And therefore, that will also influence what you do for your patients, regardless of species. And that's determined by the level of insurance that the parents or the owners have.
Okay, well, we didn't, so that's kind of the end of the main part of our presentation, but Anna has some really intriguing images that we could go through if you're able to stay on as well.
So I just wanted to show you these quickly. Some are comparative images. Some are what we do in human medicine, which isn't mainstream in veterinary practice as far as I know, but feel free to correct me. On the left side, we have a normal kidney in a dog. And on the right side, there is a kidney with hydronephrosis. It's a dilatation of the pelvis of the kidney. So this black area you can see is the collecting system of the kidney that's dilated. And when I looked at these, I thought I was looking at a human ultrasound scan that I do in my clinic. So the differences are they're not really obvious at first instance looking at them. And then the next slide is something that we do specifically in human medicine. So this is a radioisotope scan of a child who's had multiple infections, and you inject the dye. So you have to put a cannula in, and then you inject dye, and the arrow is pointing to an area where the radioisotope is not being taken up by the renal cortex. And the reason for this is because of scarring as a result of recurrent urinary tract infections. So in veterinary practice, if you have a fairly young animal present with evidence of renal failure or hypertension, it might be because of a history of recurrent UTIs that may not have been picked up. But this is part and parcel of our investigation for recurrent UTIs in children. And it would probably be not impossible to get in animals, but it certainly would be quite difficult, I can imagine, and logistically difficult. And the next image is what we call cystourethrogram. I know you do this in veterinary practice to look for certain abnormalities. And this was to show a condition that we call vesico-ureteric reflux for children, where urine reflux is a bit like acid reflux in the esophagus from the stomach. Urine reflux is up from the bladder towards the kidneys. And therefore, your bladder empties, and instead of squeezing the urine out, it pushes urine up. So you never have an empty bladder. And that can be a cause of recurrent UTIs in children. I said I was interested in spina bifida. The picture on the right is what happens with any cause for neuropathic bladder, so spinal cord injury, infections involving the spinal nerves. The bladder just doesn't contract properly anymore, and you get this very abnormally shaped bladder with lots of diverticulum and outpouchings. It's very rigid. It's not a compliant bladder anymore, and so you don't empty properly, and it's under high pressure because it's really stiff and non-compliant. So you can get reflux as a result of that as well. So if you have an animal with a spinal cord injury, they may end up with a bladder looking like this. And my understanding is spina bifida does occur in some species of dogs, and their owners are asked to express the urine to make sure that their bladder's emptying properly. And we do that in children as well. We actually get the parents to learn to catheterize their children, and they do that every 3 to 4 hours.
Oh, wow.
And that's to relieve the pressure. And the next, I think there's one more, this or two more. This is another thing that we get, which is a duplex system, where you've got two ureters coming down from a kidney, which is effectively split into an upper part and a lower part. The lower ureter tends to be plumbed into the bladder quite superficially, so you get reflux because you haven't got a good muscle tunnel preventing urine going back up towards the kidney. And then the upper section is normally obstructed due to what we call ureteric. And there's various things that we need to do to manage that depending on symptoms. And so the next one I think is of particular interest, something I didn't realise, but we see ectopic ureters in children, and they present with dribble incontinence. They never get dry, so they'll tend to turn up in my clinic with dribble incontinence. And I know that dogs in particular suffer with this. Am I right, Leslie?
Yes, dogs can. And Simon, I believe some farm animals can develop this too, right? Yeah.
Yeah, so, and it's interesting. So the way that we manage it, if providing we've got a functional kidney, we actually chop that ureter off proximally and we replumb it into the bladder. Whereas I think the main treatment for this in animals is laser ablation or laser treatment.
I'm not the best to answer that one, unfortunately. Simon, or if Deb is here, or any other vet professional that has more experience in specialized urinary cases. We'll have to look it up and get back to you on that one.
It's interesting, Simon's written about spina bifida in calves and lambs.
Yeah,
Okay.
we saw quite a bit of spina bifida when we were dealing with Schmallenberg virus in Northern Europe a few years ago.
And in Urine Island as well, and I know that Ireland's got a high prevalence of spina bifida in the human population because I've got a colleague from there. And then I think there's a couple of slides on antimicrobial resistance. So this was looking at the resistance patterns for humans worldwide and the difference between developing and developed countries. And there's certainly varying practice in the UK in terms of what antibiotic we prescribe as, the go-to first empirical antibiotic. And it depends where you are in the UK. So trimethoprim is a big no-no in London because nearly every UTI is resistant to trimethoprim. Whereas where I am up in the north of England, trimethoprim is still our go-to antibiotic. But it's a worrying trend. And the next slide is just to give us a more global feel. This has been a global talk about the risk of colistin resistance genes. And again, it tends to be focused on areas where there's quite intensive agriculture, animal farming, where antibiotics are used in feed, etc. And I know that there are a couple of studies I saw when I was doing a bit of research on the presence of antibiotic resistant E. coli in the soil and in litter found around poultry farms. So there's certainly an increasing problem that I think we ignore at our peril. And there's also been seen to be crossover resistance between animals with urinary tract infections and their owners. So if you've got an animal with a resistant UTI, there is a higher risk that the owner will have the same bug causing problems and the same resistance patterns. And there was quite a bit in popular media with regards to this about a year ago.
I'm going to go ahead and stop my screen share so I can see all your lovely faces again. And we're right at the hour. So thank you very much for joining us. I want to open it up to questions, comments. People can come off of mute and talk. Maybe raise your hand if you want. Because yeah, the main point of this was just to go over how we all speak the same language, and we just want to promote and integrate conversation and dialogue between and amongst the different medical professions. So.
Can I just say a huge thank you to both of you for putting that together? I think that's been really interesting. Yeah, look, I'm a huge One Health advocate. I've been doing quite a lot of work, including some work with Deborah, around One Health. And the crossover there in the conversation that we're having between One Health and One Medicine, is I think is quite apparent. I'm still recovering from a really nasty dose of COVID. I was hospitalized for 3.5 weeks, and despite being double vaccinated, and I think it is a good time to start talking about One Health and One Medicine. I had many really interesting discussions with my consultants in the hospital about the fact that I had worked on viral vaccines for coronaviruses, and there is an opportunity for us to kind of have those conversations across across disciplines and across professions now, and I think this type of medium for starting some of those conversations is critically important. So thank you.
Oh, pleasure. And it's been a pleasure to have so many interesting and interested people listening. I mean, I completely agree with you, Simon, that we don't actually know how common our language is until we actually get in meetings like this, and you suddenly realize there may be different words but for the same thing, but we are talking the same thing. And the one thing that the pandemic has taught us is that what affects one species isn't just in a silo. It can quite easily cause problems, not just in a small community, but worldwide. I've got to say, I agree with your hire. I hope in the future One Health's going to dominate the universe, not just global, universal. If there are any questions, I think this is a thing for Erin. Is it possible to leave the chat open?
Yeah, so the chat is open right now for anyone who has any questions, or if you'd like to network and connect with each other a little bit more, feel free to drop in your social media contacts, maybe your LinkedIn, and add your name to it as well. I think this is a good time to get to know one another, because the One Health space, unfortunately, is still small at the moment. It's still growing, but it would be great if you guys could get to know each other. Again, thank you so much for being here. Thank you, Dr. Brooks and Dr. Radford. This has been an incredible presentation. I'm sure everyone has learned a little bit of something from this. So I will be stopping the recording